Bismillah ar-Rahman ar-Rahim. I am Dr. Abo Omar, and today we will cover the topic ABG or arterial blood gases. Actually, this lecture is free lecture and open for everyone interested to understand ABG, how to read, how to interpret it, and the clinical significance. And so this lecture will be very helpful for any of these doctors candidates preparing for MRCS Part A or even Part B, and all surgeons, and also for fresh graduate doctor, internship doctor, and anyone interested, you are welcome. So I am Dr. Abo Omar. If some new friends join the meeting, they don't know about me. I am Dr. Abo Omar. I am the founder of this Scholar Academy, MRCS Scholars Academy. I am ENT consultant, and I have full MRCS in ENT, full MRCS in general surgery. Okay, so we will start our meeting by this introduction about blood gases analysis. Here, I mean by blood gases, you will take a blood sample and analyze it to check the level of blood gases. Why this will be important? Because it's a very common diagnostic tool to evaluate the acid-base status and also the partial pressure of gases in the blood. So if you measure the partial pressure of oxygen, this will give you idea about the oxygenation status of the person or the patient. And if you measure the partial pressure of carbon dioxide, this will give you information about the ventilation status of the patient. So by measuring the partial pressure of gases, it will reflect the status of oxygenation and also of ventilation. Okay, so what is the clinical significance of ABG, measuring blood gases? The clinical application or clinical significance. Some people will ask, especially if they are not internal medicine doctor or ICU doctors, maybe they will feel they are far from ABG and they are not linked or related to it. But actually, at least you have to know these basics about ABG. The blood gas analysis will help you to evaluate these all conditions. For example, some respiratory problems like bronchial asthma, acute respiratory failure, or ARDS, also in circulatory conditions like heart failure, cardiac arrest, or hypovolemic shock, and also in sepsis and septic shock, and also in complicated uncontrolled diabetes, which may lead to diabetic ketoacidosis, also in renal tubular acidosis, and can be very helpful also in follow-up of the patient. After you diagnose the patient, you need to follow up the response to the therapy and also to monitor the progression of the disease and the severity of the disease. Now, we will ask this very simple question. Why ABG? Why not VBG, venous blood gases, or arterial blood gases? Why? What is the difference? And why we will do ABG or VBG? Arterial blood gases simply means you will take the blood sample from artery, which is very accurate, okay, and more reliable and important to help you in the diagnosis. So it's the gold standard to check or assess the oxygenation and ventilation and also the acid-base status. So it's the ideal and the gold standard measure to measure the gases in the artery. But it carries some risks and disadvantages. Like what? It's painful. And by the way, it's difficult. Not everyone can do this procedure. And there is also risk of bleeding, risk of hematoma, and pseudoaneurysm from arterial wall injury can be also AV fistula, infection, nerve injury, or digital ischemia after the arterial injury. So these are the risks. And so it's not recommended everyone to try it multiple times. There are, in some hospitals, there are special technicians for ABG blood sampling, okay? Not everyone can try because there are many risks like this. About venous blood gases, also it's a simple alternative and can be helpful. So what is the advantage? of venous blood gas sampling. It's less painful and it's easy, of course, and widely used in emergency. So any nurse or any fresh doctor can make it easily in the blood sample. And also, it has good correlation with ABG in pH and bicarb. I mean, good correlation means if you measure the pH in venous and arterial blood gases, the pH will be very near to each other. Okay, similar. High correlation means it will not make a big difference if you measure the pH in blood sample or venous sample, and also bicarb. The problem will be in O2 and CO2. As you know, if you measure the O2 in artery, it will be very big difference from vein, okay, and also CO2 level. So this is the disadvantage of venous blood gases. Okay, so let's talk about the core of the lecture itself. What are the normal ranges of pH of the blood? The normal range in this green background, it will be from 7.35 to 7.45. This is the normal range of ABG. Below 7.35, this will be acidosis, and above 7.45, it will be alkalosis. So alkalosis also has this limit because after 8 pH 8, this will cause death of the patient, and below 6.9, the patient will die as well. Okay, so it's not going up forever to increase alkalosis. No, within limit, the maximum limit of alkalosis, after this the patient will die, and below 6.9 the patient also will die. Okay, so here we will apply the Rome rule, ROME, Rome rule. What is the Rome rule? Actually, RO means respiratory opposite. What is the respiratory opposite? What is the meaning of this? Respiratory opposite, the respiratory parameter or factor is the CO2. Okay, so what is the relation of CO2 with the pH? It's opposite relation, okay? When CO2 will be high, the pH will be low. High CO2 equal low pH, which means acidosis. Low CO2 cause high pH, okay, which means alkalosis. So if you look to the arrows, it's opposite. So respiratory opposite, RO. Metabolic equal. Metabolic equal means bicarb and pH going up together and going down together. So if bicarb will be low, pH will be low, and this will lead to acidosis. And if bicarb high, pH will be high, and also it will cause alkalosis. Okay, so respiratory opposite and metabolic equal. Metabolic equal, and we understand that. So also, when we study the pH and the ABG changes, we have to know that there is primary disturbance or primary problem, then a compensatory effect or response. So there is a primary disturbance or primary problem, then it will followed by compensation or correction of this problem. Okay, so in metabolic acidosis, step by step, the acidosis in general means low pH, okay? And hydrogen ion is the same parameter of acidosis. So hydrogen also, if high, it will be acidosis. Hydrogen, if low, it will be alkalosis. But hydrogen is not gas, it's not CO2. So hydrogen, it's a metabolic factor, not respiratory. Okay, so we have a three factor here: pH, hydrogen, and also bicarb and CO2. Okay, so if the pH is low in metabolic acidosis, acidosis means pH is low, and metabolic means the bicarb is low, okay, and the hydrogen is high, and CO2 is low as a result of this metabolic acidosis. The pH will be low. Why? As a response to correct this metabolic acidosis, because if the CO2 will be low, this means going for alkalosis to correct the primary metabolic acidosis. Okay, again, we will take the next example: metabolic alkalosis. Metabolic alkalosis means high pH. Why high pH? There is a problem in bicarb. Bicarb is high. As we said, metabolic equal. Okay, hydrogen ion will be low. Hydrogen ion will be low because hydrogen ion is the same like CO2. High hydrogen ion will cause acidosis, low hydrogen ion will cause alkalosis. Then the response or the secondary response will be increased CO2 to correct the primary metabolic alkalosis. Okay, so now we will discuss the four categories of ABG abnormalities or acid-base disturbances. We have four categories: two respiratory and two metabolic. The two respiratory problem, respiratory here means the lung action, the lung function, the pulmonary system or lung. So it's mainly deal with gases, which is the main one is CO2. Okay, CO2 is the main factor in the respiratory system, which controlling and directly affect the ABG and acid-base disturbances. So how we control this CO2 level? What are the factors? How the lung controls the CO2 level? By hyperventilation. Hyperventilation, rapid or deep breathing will wash out CO2 from the body. So it will lead to low CO2 level in the body. Okay, hypoventilation, low respiration, slow or shallow breathing. This will retain more CO2 in the blood, in the body. No wash out. So the CO2 in the body, in the lung and in the blood will be higher. It will increase with hypoventilation, but it will decrease with hyperventilation. Hyperventilation means wash out of CO2. Okay, and also CO2 affected by the acid-base status as a secondary response. If we have metabolic problem, CO2 will be affected according to the primary problem, as we mentioned in the previous slide. Okay, so the first one in the respiratory, we will discuss respiratory alkalosis. Okay, alkalosis, as we said, means the pH is high, and respiratory means the problem in CO2. So the high pH and the problem in CO2 means it's opposite. So there is low CO2. Low CO2, high pH, alkalosis, and low CO2 by what? By hyperventilation. Okay, so there is wash out of CO2. To know what are the causes of respiratory alkalosis, simply we need to know what are the causes of hyperventilation. And this table of causes of hyperventilation may be psychological, like anxiety, fear, pain, high metabolic demands like fever, sepsis, medications like respiratory stimulants like salicylate, nicotine, CNS lesions, stroke, subarachnoid hemorrhage, and so on. Okay, so we need to know what are the causes of hyperventilation, which will wash out CO2, means low CO2, means high pH, and finally it's respiratory alkalosis. Okay, we have salicylate. Salicylate as a drug has a special effect, actually. Why? Because it acts by two mechanisms together, not one of them. Together they will act, but one after the other one. What is the effect of salicylate overdose? Salicylate overdose finally will cause mixed respiratory alkalosis, as we mentioned before, low CO2, high pH, and also it will cause metabolic acidosis. This can be done? Yes, we can find one patient, one person with respiratory alkalosis and metabolic acidosis in the same patient. It's not impossible. It comes like this. So how it will occur with salicylate? Early, the salicylate will stimulate the respiratory center. We just mentioned that. So it will stimulate the respiratory center, and this will lead to hyperventilation and respiratory alkalosis. We just discussed it. Then, after overdose and after sometimes, this salicylate will accumulate, and so it's acid. If you remember, salicylate is a salicylic acid. So when it accumulates and causing renal failure also, this will lead to metabolic acidosis. Here, the mechanism of metabolic acidosis away from CO2, away from lung, and so it's not respiratory problem. Okay, it's metabolic from the effect of overdose of salicylic acid. So it will cause what? Finally, it will cause respiratory alkalosis plus metabolic acidosis. You can say mixed respiratory alkalosis and metabolic acidosis. Okay, The next one or the second problem in respiratory system will be respiratory acidosis. Again, acidosis means low pH and means high CO2. So high CO2 by hypoventilation. Okay, so high CO2 will form what? If there is high CO2, if you look to this equation, high CO2 will combine with water to form carbonic acid. Carbonic acid means acidosis. Okay, so this is the effect of hypoventilation with accumulation of CO2 in the blood. What are the causes of hypoventilation? To know what are the causes of respiratory acidosis. Here, many causes of hypoventilation can lead to the same effect. So like CNS depression, if there is head injury, some medications like narcotic or sedative, sleep disorders, cerebral ischemia, chest wall problems causing hypoventilation, low breathing, slow breathing, like chest wall injury, deformity, kyphoscoliosis, or flail chest. Also, if there is ventilated patient, and there is ventilator dysfunction, okay, can cause also hypoventilation. And also the respiration itself, the respiratory process itself require normal respiratory muscles, normal nerve supply of these muscles. So if there is any defect in the respiratory muscles or the nerve supply of these muscles, it will cause also hypoventilation. So like what? Like neuropathy, myopathy, spinal cord injury, and so on. We finished respiratory causes or problems. Now we will talk about metabolic disorders. Metabolic disorders, the word metabolic means anything non-respiratory, anything not related to CO2 or not related to the lung means it's metabolic. Keep this rule by this way. Okay, so never confused. If there is no CO2 rule in any abnormality, this means it's metabolic. So it may be renal, it may be GIT problem, it may be tissue problem, and whatever. So it's not related to the lung as a primary problem. Okay, so it will affect what? Anything other than CO2, also like bicarb, hydrogen ion, or acid production. Okay, by what? What is the effect? By increase the bicarb or decrease the bicarb, increase hydrogen ion or decrease or increase acid production. So the metabolic means anything non-respiratory, mainly in renal or GIT, affecting three factors, maybe bicarb or hydrogen ion or acids. How is the effect? Maybe by increased production, or increased excretion or retention, or increased reabsorption if there is renal effect. So the first one in the metabolic will be metabolic alkalosis. Okay, metabolic alkalosis, again, alkalosis means high pH. Metabolic means problem in the bicarb mainly. So bicarb will be high or low with metabolic alkalosis? It will be high. High bicarb cause high pH, which is metabolic alkalosis. Okay, what is the mechanism that the bicarb can be high? Maybe there is gain of bicarb, increased level of bicarb, or loss of hydrogen ion. Loss of hydrogen ion, as we said, hydrogen ion is the acidic factor. If it's high, it will cause acidosis. If it's low, it will cause alkalosis. Again, hydrogen ion, not respiratory factor, it's metabolic because it's not CO2. So as we mentioned, anything other than CO2 or respiratory problems will be metabolic. So if hydrogen ion will be low, this means there will be high bicarb also, or high alkali or bases. Why? Simply because hydrogen ion, if we have any base, if the hydrogen ion combined with this base, if we have any base like this, if attached to hydrogen ion, it will become acid. Okay, any base or alkali with hydrogen ion, it will convert it to acid. So if there is low hydrogen ion, means high bases or alkalis. Okay, like bicarb will be high also. Okay, okay, so let's discuss the details of each one. Loss of hydrogen ion. How hydrogen ion can be lost. How? Like one mechanism, which is very common and simple, intracellular shift of hydrogen ion. Hydrogen ion can be shifted from the blood into inside the cell. Okay, so it will go inside the cell. Why this will happen? If the patient has hypokalemia, low potassium level, if there is low potassium level in the blood, okay, let's draw it. We have this is the cell and this is the blood. Simply the relation of potassium and hydrogen is opposite. Okay, they usually in exchange to each other. So let's start with the potassium, and this is the blood as we said. In the blood, if there is low potassium level, what will happen? Simply to correct this hypokalemia, we need to shift the potassium from inside the cell. Here it's intracellular. So we need to take the potassium from intracellular to the blood. So this potassium, if it will go outside to correct the hypokalemia, this will be in exchange with what? With hydrogen ion. This will lead to low hydrogen ion in the blood. Okay? This is one of the forms that hydrogen ion can be lost. Intracellular shift of hydrogen ion in case of hypokalemia. Okay? Okay. Next way or next method of hydrogen ion loss may be by GIT loss of hydrogen ion. Okay, like what? Like large volume loss of gastric secretion with vomiting or nasogastric suction. As we know, there is hydrogen ion in HCl. It's HCl, hydrogen ion in the HCl. So with vomiting or nasogastric suction of the stomach, it will cause also loss of hydrogen ion. Okay, another mechanism of hydrogen ion loss by renal loss. Renal loss here by what? By sodium. When we need to reabsorb more sodium, it will be also in exchange with hydrogen ion. Okay, the same idea of intracellular shift, but here not potassium, sodium. Sodium is the antagonist or the co-transport of hydrogen. When sodium reabsorbed in the kidney, in the collecting duct, the hydrogen ion will be lost in exchange with sodium. So we need to know if there is increased sodium reabsorption, the hydrogen ion will be lost. Okay, why sodium will be reabsorbed? By the effect of aldosterone. So the aldosterone will lead to increased sodium reabsorption, hydrogen loss in urine. Like what? Like in Conn's syndrome. What is the Conn's syndrome? In Conn's syndrome, there is high aldosterone level. High aldosterone level. This will lead to, in Conn's syndrome, there will be hyponatremia, hypokalemia, and hydrogen ion loss in the blood, in the urine. In loop and the thiazide diuretics, here also in diuretics, there will be increased sodium and fluid loss. This will stimulate RAS system. Okay, renin angiotensin aldosterone system. RAS will lead to secondary hyperaldosteronism. So secondary hyperaldosteronism also will lead to increased aldosterone, which will lead to more sodium reabsorption and hydrogen loss. Okay, now we discussed the causes of hydrogen ion loss. Three causes: GIT, renal, and intracellular shift. The second half of metabolic alkalosis will be related to bicarb loading or gain of bicarb, increased bicarb. We have also specific causes of this, like what? Like transient metabolic alkalosis. Transient means temporary metabolic alkalosis, which will be immediately after sodium bicarbonate, oral or injection, and citrate also. If the patient receive blood transfusion, the blood transfusion, the packed blood or the transfused blood contains citrate, which is alkali or base. So this will lead to transient metabolic alkalosis. Why it's transient? Because it will be rapidly corrected. Okay. The other cause of bicarb loading will be milk alkali syndrome. This is a psychological syndrome. Patient will consume excessive amount of calcium and milk. So it's called milk alkali. Milk means excessive calcium. And after, why the patient receive all this excessive milk and excessive calcium in the milk? Because the patient has psychological problem and fear of hypocalcemia and osteoporosis, more common in female. They are worried about osteoporosis, so they, as a protective measure, they drink more amount of milk, and even they receive calcium supplementations to avoid that. This hypercalcemia finally will lead to what? Will lead to gastritis and hyperacidity. Okay, so the patient will feel that he need antacid drugs. So it's called milk alkali. This antacid drugs is alkali, anti-acid, so it's alkali. So the patient can develop also high bicarb level and alkalosis. Okay. The other cause of bicarbonate loading or increased bicarb level will be post-hypercapnia metabolic alkalosis. This metabolic alkalosis occurs after hypercapnia. Hypercapnia or post-hypercapnia means high CO2 level in the blood. So how is the sequence? What is the sequence of this condition? The patient has hypoventilation for any reason, it's not specific, hypoventilation. So there will be CO2 retention, which will cause acidosis. Okay? Okay. This respiratory acidosis from CO2 retention, it will start to stimulate the kidney to compensate. How the kidney as a system will compensate the respiratory acidosis resulted from CO2 retention. How the kidney will compensate this? The kidney will retain bicarb to correct the pH. If kidney retains the bicarb, it will make alkalosis, metabolic alkalosis, to correct the respiratory acidosis. Okay, so now you as a doctor will interfere to correct the cause of hypoventilation. You will not keep the patient and the body manage itself like this. You need to correct the cause of hypoventilation. So you will correct it also, whatever you can manage the cause, or doing any intervention to correct the hypoventilation and correct the wash out of CO2. You wash out CO2. So what will happen? CO2 will be quickly or rapidly decreased after you correct the hypoventilation. But what will happen? The bicarb will take longer time to reduce again. So we have high bicarb to correct the respiratory acidosis. Respiratory acidosis will be corrected very quickly, but the high bicarb level resulted in the compensation before, it will lag and it will stay longer time. This means also post-hypercapnia metabolic alkalosis. Okay. Another thing or another mechanism of bicarb, increased bicarb level, will be loss of large volume of fluid, and this fluid contains more sodium and bicarb, low bicarb. This means high bicarb level, so it will increase the bicarb level in the blood. Like what? Like in cystic fibrosis. This is example. Hereditary condition, cystic fibrosis, there will be excessive sweet. Okay, and this sweet sodium chloride loses. Okay, so extracellular fluid volume contraction and chloride depletion. This will stimulate RAS system, and RAS means renin angiotensin aldosterone system, and finally we mean there will be aldosterone. Okay, if the kidney is normal, and functioning, it will excrete this high bicarb. Okay, so the kidney can manage this high bicarb from contraction or loss of fluid. So if there is loss of the fluid, this fluid contains more sodium and low bicarb, the kidney can manage and excrete this excess bicarb in the urine. But if the kidney is diseased, it can't eliminate this high bicarb, okay, stay in the blood, so it will resulted in metabolic alkalosis as well. Okay, now we finish the metabolic alkalosis. So let's discuss the fourth and the last part of the four conditions, which is metabolic acidosis. Okay, metabolic acidosis. Again, acidosis means low pH. Metabolic means non-respiratory, other causes other than CO2 changes. So, and the pH will be low. And here, metabolic means also bicarb will be low. Okay, so what are the mechanisms of acidosis here in the metabolic acidosis? Maybe there is loss of base, loss of alkali. Okay, so alkali will be low, and so it's metabolic acidosis. Like what? Like intestinal fistula or diarrhea. There will be loss of bicarb and alkali in from GIT, and this will lead to metabolic acidosis. The other mechanism of metabolic acidosis not related to bicarb itself, it's related to increased production of acid. So it's acidosis due to increased acid production, which will lead to also metabolic acidosis. So acid is not respiratory, is not pulmonary, not CO2. So we will consider it a metabolic mechanism. Like what? Like diabetic ketoacidosis. Here, there will be keto acid, increased production of keto acid. Renal failure, there will be low excretion of excess acid in the blood. Anaerobic metabolism, also there will be increased lactic acid in anaerobic metabolism. Also in starvation or salicylate intoxication, we just mentioned in salicylate overdose, there will be metabolic acidosis. Okay. Anion gap, this is a specific point to discuss, but it's related mainly to metabolic acidosis. So, what is the anion gap? Simply, anion gap, it's a gap between the major cation and the major anion. Okay, so it's the difference between major cation and major anion. What is the cation and what is the anion? Anion here, AN. This N means it's negative ion. Anion, negative ion. Cation, positive. Okay, so to remember this, anion is the negative ions. We have ion, which may be positive or negative. If it's negative, it's called anion. And if it's positive, it's called cation. Usually, the body has a neutral electrochemical condition. But why there is a gap? Why there is a difference between anion and the cation? Due to some cations and some anions are very minor that we can't measure. We can't measure the minor cations and the anions. So there will be a gap. So the gap is only laboratory gap. We can't measure the minors, so there will be a gap. Okay. So what is how to calculate this anion gap? Sodium is a positive one plus potassium. These two are cations. The sum of sodium and potassium will be minus the bicarb and chloride. So we will sum the anion together, bicarb and chloride, and subtracted from sodium and potassium. Okay, normally it will be from 10 to 18 millimole per liter. This is the anion gap normal level and the equation. Maybe you can find this equation without potassium in some sources, and it's okay. Potassium is very low level, and its effect on the result of anion gap is very minor effect. So we can cancel it in some equations, and it's accepted. No problem about that. Okay. So in this equation, we will look to bicarb. Bicarb is a metabolic factor. Okay. So bicarb is a metabolic factor. If bicarb is low, what it will cause as effect on acid base, it will cause acidosis. So if bicarb is low, focus here, please. We have sodium plus potassium minus bicarb plus chloride. Okay, this is the anion gap. We will look for bicarb. We know from the start that if bicarb is low, means pH low, means metabolic acidosis. Okay, clear this rule? If bicarb is high bicarb means high pH, means metabolic alkalosis. Okay, these are the basic rules. So in this equation, we will look to bicarb, and we have metabolic acidosis. This means low bicarb. If there is low bicarb, what is the effect of low bicarb on the anion gap? Pure mathematical question. If the bicarb is low, simply you can expect that the anion gap will be high. Why? This value will be the same, and this value will be decreased. So the anion gap will be high, increased. Why? Because the bicarb will be low. Clear? Hello? Hello?
Clear, clear.
Okay, continue.
Clear. Clear. Continue.
Okay, so we are here. So bicarb is a factor of metabolic problem. So related will be direct relation with the pH, and so if bicarb is low, there will be metabolic acidosis. Okay, so what is the effect of low bicarb on the anion gap? It will be high. Yes, but it's not usually the condition. Why? Sometimes there is low bicarb, okay, low bicarb, and the anion gap is normal. Why? How? What is the explanation of this? What is the mechanism of this? The mechanism of low bicarb and still the anion gap normal is the
Floor.
explanation. Also, mathematical question. The chloride will be high. If the chloride increase, this will compensate the decrease in the bicarb and will keep the main value, the sum of this value, the same. So the anion gap will be normal or within the normal level. Clear? So here the chloride will be in standby. Maybe it will be increased or stay as it without increase. If the chloride stay normal without increase, the anion gap will be high. If the chloride increase to compensate the defect or the decrease in the bicarb, the anion gap will be normal. Okay, so again here metabolic acidosis will be divided into or classified into two types. In metabolic acidosis we have low bicarb, so anion gap depend on the chloride level. If the chloride level stay normal unchanged, okay, so the anion gap will be, if the no increase in the chloride, the anion gap will increase. Okay, and it's called raised anion gap metabolic acidosis. It's a type of metabolic acidosis. The other one, if the chloride increase in the chloride level, it will compensate the defect, and so it will cause normal anion gap metabolic acidosis. It's metabolic acidosis. Why? Because there is low bicarb. But why it's normal anion gap? Because the chloride increase to compensate. I hope it's clear for everyone. Okay, so now we will discuss some causes of normal anion gap and some causes of high anion gap metabolic acidosis. Normal anion gap metabolic acidosis, here the primary problem is loss of bicarb. Loss of bicarb. So, and the chloride will be high. Okay, so it will keep the anion gap normal. Like what? Like diarrhea, pancreatic fistula, renal tubular acidosis, acetazolamide, and Addison disease. In this condition, there will be loss of bicarb and the chloride will be high. By the way, also, we have another effect of these conditions. As we know, as we mentioned, the anion gap sodium plus potassium minus bicarb plus chloride. In this condition also, in these conditions, there will be loss of bicarb and also loss of sodium or potassium. So this value will be low and this value will be low. So the chloride here will be high. We can call it a very specific name, relative hyperchloremia. Why relative? The chloride is not affected, not changed, but chloride level in relation to potassium or sodium will be high. Okay, so the anion gap also will be normal anion gap. Okay, so high chloride doesn't mean the real level of chloride will be high. No, some like what? Like in diarrhea. In diarrhea, there will be loss of bicarb. Someone will ask, why high chloride in diarrhea? Okay, no, it's not like that. In diarrhea, there will be loss of bicarb and also loss of potassium and sodium. So the cation value will be less and the anion value also less. There is loss of bicarb, but here the chloride will make the balance, and so the anion gap finally it will not be changed, so it will be normal anion gap. Okay, the other factors, the other type is raised anion gap metabolic acidosis, and here the chloride will be normal and there is increased acid production. So it will cause acidosis by increased acid production. There is no loss of bicarb outside the body. Actually, in these conditions, bicarb will be exhausted or consumed to neutralize the acid production. Okay, if you look to these causes, we have a source of acid. Okay, we have a problem producing more acid. So this acid, how this acid will be neutralized? It will be neutralized by using what? By using bicarb. So the anion gap will be affected because we use the bicarb in the anion gap to compensate high acid level. So and here chloride will not be changed, sodium will not be changed, potassium also will not be changed. So there is increased acid, there is use of bicarb to compensate and neutralize this acid. Chloride is normal, okay, not increased. Sodium, potassium also the same. So the anion gap will be increased, the anion gap will be raised. We only change one factor of the four factors of anion gap. I think it's clear. So like what? Like high lactate in lactic acidosis, hypoxia or shock, high ketones like diabetic ketoacidosis, also diabetic ketoacidosis, alcohol ketoacidosis, or starvation. There will be abnormality or increased fatty acid metabolism. This will lead to also starvation ketoacidosis, renal failure, or acid poisoning, again like salicylate intoxication. Okay, this diagram will show will help to understand the anion gap. Okay, so here they put sodium alone without potassium, and there will be chloride and also bicarb, and Ag means the anion gap, the difference. Okay, so the sodium or the cations itself with the green color will opposite to the chloride, the bicarb, and the gap, this normal one. Okay, so if you look to the middle bar, the bicarb become low. Yes, bicarb become low. There is metabolic acidosis. Okay, and the anion gap increase. If you look to the chloride, chloride is the same. Chloride in the middle one, the same like the first one. So no change in the chloride. This means anion gap become more, raised anion gap or high anion gap. In the third bar, the sodium the same. Here, bicarb also decreased from the first one. If you look, bicarb become less, means metabolic acidosis. Chloride here increase, and it compensates the loss of bicarb, so it keeps the anion gap normal, like the first one. Okay? Okay. Another point, which is base excess, not so much important, but it's okay. So, base excess means what is the amount of the strong acid you must add to the blood. Okay, the specific definition not so important, but the clinical application is important. Later on we will use. So the strong acid, amount of strong acid that must be added to each 1 liter of the blood to return the pH to 7.40. 7.40 is the middle of the normal average of the blood pH. Okay, at the same temperature of 37 and so on. This condition means you will add specific amount of strong acid to correct the blood pH to be 7.40. 7.40. There is also base deficit. What is the amount of strong base to be added? What you need from base excess, you need to know only the normal range. The normal range is -2 to +2. Okay, this is the normal range of base excess. What is the application? What it reflects? In some scenario, in some questions, they will not give you the bicarb level. Okay, so it will be in the same idea or the same concepts of bicarb. If base excess high, this means metabolic alkalosis. If base excess is low, this means metabolic acidosis. We don't need to know more about it except the last 2 lines. If base excess high means metabolic alkalosis, if you look, it's like bicarb. If base excess is low, this means metabolic acidosis, and the normal range also is important. Okay. After the primary problem of acid-base disturbances, the body will not stay like that. The body, from the homeostasis and the normal physiology, will try to correct. As we know, it's a very serious condition to keep the body in acidosis or progressive alkalosis. The body spontaneously will respond to correct the problem, the primary problem, which is compensatory mechanism or compensation. So if the problem is metabolic, the respiratory will compensate and correct. If the problem is respiratory, the kidney or the renal system will compensate. So respiratory compensation will make its rule by regulate the CO2 by retention or elimination of CO2, and it's very fast, like emergency compensation. So it will start within 1 to 3 minutes, very fast. It's only just hyperventilation or hypoventilation. Within few minutes, it can start the action and correct it, but it's not strong. It will only can manage or correct the mild or moderate problem only. Kidney is regulating or compensating the respiratory problems also by regulating the bicarb level by excretion or retention, and it's late. It starts in hours, but stay very long. If you remember, post hypercapnic metabolic alkalosis, so renal effect will be stay longer time. Okay. Okay, here some bullets or some clue to deal with to remember the clinical causes and the conditions with the relation of ABG. Okay, so respiratory alkalosis, pulmonary embolism. Pulmonary embolism will cause respiratory alkalosis. COPD will cause respiratory acidosis. COPD, C acidosis. Okay, and pulmonary embolism will cause alkalosis. Then metabolic alkalosis by hypokalemia or vomiting. So to remember, vomiting going up. So the pH will go up, alkalosis. Diarrhea will go down. So pH also will go down, acidosis. And the other causes of metabolic acidosis like dehydration, shock, renal failure, hyperglycemia, and salicylate, and hyperkalemia, as we mentioned before. Okay, how to read ABG? Before starting, this is the third part of our lecture. We can take a break of recording and asking if there is any question. Any question in the previous part before starting the third part of the lecture? Hello? Continue?
Yeah, continue.
Continue.
Everything is okay? Everything is clear for everyone? Okay, so continue.
How would be how will be the presentation when how they present as a question on exams?
We will discuss in the practice. We have the last part in the lecture will be practice, how to solve the questions. Never worry. There is another part about how to apply all that knowledge in questions. Okay? Okay. So how to read ABG? In few steps, you will look first for pH. And the parameter, the normal parameter, you must memorize very well. Never forget. Okay? So first look will be for the pH, which is 7.35 to 7.45, and you will keep your eyes. Is it normal or high or low? So if it's normal, okay. If it's alkalosis or acidosis, then you will look for the primary cause to know what is the primary problem causing this acidosis or alkalosis. So for myself, you can start for CO2. I think better to go for after pH, then go to CO2. Fix your mind by this sequence. CO2, you will look for it. And you will remember the normal range of CO2, 35 to 45 millimeter mercury or 4.5 to 6 kilopascal. Both units should be memorized and remember in exam. Okay? Not only one. Most of people remember only 35 to 45 millimeter mercury, but all required to keep in your mind. So you will look for CO2. If there is high CO2, this means acidosis. If low CO2, this means alkalosis. Then you will look for the bicarb. Again, the normal bicarb, 22 to 26 milli equivalent per liter. If it's high, it will be alkalosis, and so on. After you find the primary problem, it's respiratory or metabolic, then you will go for the compensation. Is there compensation or no? Maybe you will find full compensation, partial compensation, no compensation. So there will be full compensated problem, or partially compensated, or no compensation at all. And we will discuss the details of compensation soon. Okay. This is a separate question. What is the drug causing lactic acidosis? It's metformin. The question in exam come by this way, directly, without the mechanism. So the drug causing lactic acidosis is metformin. Why metformin causing lactic acidosis? Metformin will inhibit the hepatic gluconeogenesis of Cori cycle. So there will be excess lactate. Cori cycle using lactate for glucose. So for glucose synthesis. So if this cycle inhibited, there will be excess lactate. So it will cause lactic acidosis. Okay. Another two questions. How to differentiate normal ABG from full compensation? By the way, full compensation means what? What is the meaning of full compensation? We have a primary problem, like, for example, we will start respiratory acidosis. Again, what is the meaning of respiratory acidosis as a primary problem? Respiratory acidosis means low pH, and respiratory means CO2 problem, which means low respiratory acidosis, low pH and high CO2. Okay, high CO2 and low pH. This is the respiratory problem. Then, what is the compensation for this problem? The compensation will be one of these three possibilities. Maybe the kidney not started compensation yet. The kidney is nothing, not responding, ignoring this respiratory acidosis. Okay, again, we will focus with this example and you will apply in all other conditions. So we have here respiratory acidosis. Acidosis means low pH. Respiratory acidosis, abnormal CO2, which is high CO2. Respiratory acidosis. What are the possibility or the types of compensation that occur here in this condition? Maybe no compensation at all. Okay, how you will know there is no compensation? You will look for the bicarb, the renal factor. If the bicarb is normal, this means the kidney ignoring this problem, not compensate, even not start to compensate. Okay, so we have high CO2, low pH, normal bicarb. This means no compensation. Okay, this is the first condition you can find. Okay, the other possibility, the kidney noted that there is a problem, there is high CO2. I need to compensate that. How I will compensate? I will retain bicarb. I will retain bicarb. Why? If the kidney retain bicarb means increased bicarb means metabolic what? Metabolic alkalosis. This metabolic alkalosis to correct what? To correct respiratory acidosis. Okay, so here compensation started. Okay, and the next question directly will be: is this compensation is partial or not complete, or it's full or complete compensation? How to know it's partial compensation or full compensation? How to know? You will look for the pH. Okay, you will look to the pH. If the pH retain again to the normal, this means the kidney did the job very well and it corrects the pH. Okay, so you will find here in the respiratory problems, you will find high CO2, okay, and low pH. So if there is full compensation, you will find the pH become normal again. So what is the final result of full compensation? You will find in the full compensation normal pH, high CO2, high bicarb. You know, okay, normal pH. Normal pH means maybe normal ABG or full compensated problem. If you find normal pH, this means one of two things, only two possibilities. Normal pH may be normal ABG. What is the normal ABG? Means normal pH, normal CO2, normal bicarb. Everything is normal. So normal ABG, you will find normal pH. Okay. And the other possibility of normal pH is full compensated problem, as we said here, respiratory acidosis, okay, with compensatory metabolic alkalosis, high bicarb, high CO2, normal pH. This means full compensation. Okay, so these are the mechanism of compensation. Okay, again to revise it, full compensation means normal pH, abnormal bicarb, and abnormal CO2, whether high or low. So both the factors will be abnormal, but the pH is normal. Okay, how to know the primary problem? Okay, I will ask you a simple question. Now you find normal pH, high CO2, and high bicarb. Someone can ask a very logic question. If there is high bicarb causing metabolic alkalosis, okay? Metabolic alkalosis. If there is high CO2, it causes respiratory acidosis. Okay, now you find this ABG. You find normal pH, you find high bicarb and high CO2. We can go in this direction and we can go also in this direction. If the primary problem is high bicarb, okay, high bicarb is a primary problem. So it will be compensated by high CO2, respiratory acidosis, to correct it. And in the other direction, we can go also. If there is high CO2 is the primary problem due to hypoventilation, there is respiratory acidosis, it will be compensated as well by retention of bicarb, increase the bicarb, metabolic alkalosis, which will also correct the respiratory acidosis. And in both directions and in both conditions, the pH is normal. Okay? How you will know what is the primary problem and what is the compensatory effect? Anyone know? Anyone know the answer for this question?
Look at pH value.
Yes, excellent. Excellent. So you will
Yes.
look to, excellent, Dr. Muhammad. You will look to the pH. Okay? Here, this table is very important and very nice to summarize it. So you will look for the pH. If it's normal, okay, alkalosis or acidosis, as you see, then in the normal range, you will divide it into two halves, acidotic half and alkalotic half. Acidotic half means the acidotic half below in the normal range from 7.35 to 7.40. We will make the 7.40 is the cut point between acidosis and alkalosis. So if the pH in the acidotic half, it will be less than 7.40. If alkalotic half will be higher than 7.40 till 7.45. Okay, so we have alkalotic half and acidotic half of the normal pH. Okay, so what is the meaning of every one of this? If you find the pH is normal, but it's in the acidotic half, this means full compensation of acidosis. The primary problem is acidosis. How? If you find the pH in the acidotic half of the normal range, this is the normal range, this is the acidotic half, and this is the alkalotic half. If the pH is here and here, this is acidosis, and after that, alkalosis. If the pH lies here in the acidotic half, this means this pH coming from this direction. So it was acidosis and corrected to become normal. Okay? Okay. If you find the pH in the alkalotic half, this means this pH is normal. Yes, it's normal. It's in the normal range. Okay? But it lie in the alkalotic half. This means in the start, this pH was alkalotic and it's corrected and enter the normal range from this direction. So it was alkali. Okay? It was alkalosis. So in this condition that we see now in the screen, how to know this is the primary or this is the primary, acidosis is the primary or alkalosis? You will look for the pH. Okay? If the pH here in the normal range, but it's here, this means alkalosis is the primary problem. Okay? If the pH is here, this means acidosis is the primary problem. And both are normal pH. Okay? But if in the alkalotic half, it will be alkalotic problem and the acidosis is the compensation. If it's here, this means the acidosis is the primary problem and the alkalosis is the compensation. Okay? Clear?
Okay.
Okay. We have finished the main lecture and now we will go for practice. Okay? So anyone interested to go with us in practice? Hello? Hello?
Yeah, we are interested.
Okay, so practice here, we will solve a full questions and some quizzes about ABG interpretation. Okay, so raise your hand. Anyone interested? Raise your hand, please. So, hello? Dr. Subrata. Okay, and Dr. Sham, and then also Dr. Kitama. So we will start one by one. Okay, so Dr. Subrata, start the first question. Okay,
Which
start
of the
reading.
blood-
Read the question.
The blood gas result listed below is most likely to fit with a patient who has acute respiratory acidosis.
Yes. What is the question? The question asking about which picture of ABG will be compatible or comparable with the acute.
Acute.
Every word is important. Acute respiratory acidosis. Before look to the table, please. What is the meaning of acidosis, Dr. Subrata? Acidosis means what is the pH?
pH less than 7.35.
Yes. So you will look for acidosis first. Then you will look for abnormality in CO2. Then you will look for the compensation. Okay. So let's start with the acidosis or pH. Here, by the way, another trick for the exam. Another trick for the exam. And in ABG question or any question contains the table by this way. 5 row and 5 columns by this way. So you will not go vertically reading column or every row. You will not go vertically, horizontally. You will not go horizontally in each row. You will go vertically. How? For example, if we start to read line by line, so you will read option A all and option B all, and you will waste time and confuse. So in exam, you will go vertically. Okay? In this exam or any exam contains table by this way and multiple point in each option, better to go vertically. Why? Because from the first column, we can exclude some answers. Like what? Now we talk about acidosis. So is 7.57 acidosis?
No.
No. So you see, from the first cell in the first option, you can exclude option A. Okay? Clear?
Yeah.
Yes. Option D, 7.36. Is it acidosis?
No.
No. You see? From one number only, exclude the whole line. No need to read all these numbers. No need. خلاص. First, finish. From the first number, you will cancel the full option. Okay. Now we have 3 options to select. And all are acidosis. Then we will go for the next column. Next column. In the next column, we will look for CO2. It's a respiratory problem. We must expect that the CO2 in respiratory acidosis to be high or low.
High.
Perfect. So what you will exclude? You will exclude low CO2. Like what?
E. Number E, I will exclude.
Excellent. Here, you see? Exclude. So you will not read this or all that excluded. Now we have option B and option C. Okay? Okay. How to know it's option B or C? From the word acute. Acute means what? Acute means acute respiratory problem means the kidney not yet start to compensate. Okay, the kidney,
Okay.
we told it will take time to compensate. It will not rapidly compensate. So you will look for the bicarb. In option C, bicarb is low.
Low.
This means the kidney compensate. Okay, but
Yeah.
in sorry,
Option B. Option B.
yes. So answer is B. Here the bicarb is normal. There is no compensation because it's a acute condition.
Acute condition.
Yes, excellent. Who else like to participate? Next question. Hello? Hello? Anyone? It's okay. Anyone can read with me. Dr. Kitama? Hello?
I can continue if anybody not interested.
Yes, continue. Anyone can continue.
Which of the condition listed below is most likely to account for the following
Raise your voice,
arterial?
please, Dr. Subrat.
Which of the condition listed below is most likely to account for the following arterial blood gas result? pH 7.49,
What
PO2
does this mean? What does this mean?
alkalosis,
Yes.
PO2 8.5, bicarbonate 22, PCO2 2.4,
Bicarbonate is
Chloride.
normal or high?
Normal,
Yes.
PCO2 2.4, and chloride 12 milli equivalent.
CO2 is what? Normal or high?
CO2, not normal,
High or low?
low.
Yes. So low CO2 and high pH directly means
High pH means alkalosis.
Alkalosis.
yes.
Alkalosis, and it's respiratory alkalosis.
Yes. Yes, perfect. Next. Anyone else or Dr. Subrata will continue? Hello? Anyone like to continue? Dr. Hiba, Fahmida, anyone? No one? So, okay, continue, Dr. Subrata. Third one.
Which of the following blood gas result would fit the metabolic acidosis with a compensatory respiratory alkalosis?
Tell us how you think, what you are saying.
Metabolic acidosis means pH low, which is number B, number D, and number E.
So you will exclude what?
A and C.
A and C. Yes. No. C, compensatory
C.
respiratory alkalosis. You will exclude normal pH and sorry. Yes, metabolic acidosis. So you will exclude alkalosis. Yes, I look for here. So you will exclude alkalosis, okay, and also normal.
Normal A.
Yes. So B or D or E.
Metabolic.
So we will look for CO2.
Yeah.
If the CO2 is normal, you will exclude it. Why? Because they said already there is compensation. And the compensation means CO2 will change to compensate.
That means kidney working right now for compensating.
No. Here the primary, they told you clearly in the stem. The primary problem is metabolic acidosis. And the respiratory compensation will be fast and rapid, no problem about this. So you will look for
the problem is
CO2.
metabolic.
You will exclude normal CO2. Why you will exclude normal CO2? Because there is compensation and CO2 can't be normal. CO2 will be high or low according to the primary metabolic problem. Primary metabolic problem is metabolic acidosis. So we need the CO2 to be low. Why? To compensate. It will cause respiratory alkalosis to compensate the primary metabolic acidosis. So what you will exclude? I will exclude high CO2 and also normal CO2. In the second column, here, the first column, we exclude this wrong and this wrong. So the full column will be excluded. In the second column,
I'm
of
sorry,
CO2,
I have a question.
hello?
Sorry, I have a question, please.
Yes? Continue.
The question says that respiratory compensation occurred. So the pH shouldn't be in the normal acidic any part from 7.35 to 7.40. So why we excluded the choice A?
We exclude because still it's not full compensation. Not full.
How we know the question means full compensation or partial compensation?
Yes, there is compensatory respiratory alkalosis. Yes. So here we will exclude the alkalotic pH. Yeah, CO2 can, yes, CO2 can, pH can't be excluded from the first line. Yes, you are right. But actually, because usually respiratory will not cause, this is from our experience, you will find it with solving more questions. Respiratory usually will not cause full compensation. Okay, usually. But anyway, so in this option A, pH is normal, can be normal if there is full compensation. Yes, keep it now to exclude later. Okay.
Thank you.
Yes, you are correct. So from
Thank
the
you so
first
much.
column, we will exclude this one. I excluded it because I know the answer first, and also I know that respiratory usually will not cause the effect like this. Okay. So it will be excluded, by the way. But why? Later on in the third column, we will exclude it. Okay, doctor. Continue with us, doctor. Hello? The one who asked.
Hello, me. Yeah.
Yes, continue with us. So about CO2, which options you will exclude? If there is respiratory compensation of the metabolic acidosis, which options you will exclude?
The option was high CO2.
Yes, like?
So
Honey.
CO2 in the A, it's high,
Yes.
7.3. So we
And
exclude
then,
the choice A. And E, and
yes.
also B.
Option B is also high.
Yes.
Yes, I said B. So it's remain the choice D.
Yes.
The correct choice.
Yes. Excellent. Okay.
Thank you.
So here we will not go for all these numbers. Numbers are confusing in exam. So you go vertically by this way. Okay. Next one.
Shall I continue?
Yes, please.
Which of the following blood gas results would fit with the respiratory acidosis with a compensatory metabolic alkalosis? So first we look for the pHs that are low or in the acidic range, any
Yes.
compensated acidic range. So I'll exclude the choice B, the choice D, sorry. D is alkalotic.
Yes.
And all other choices will remain. And then I'll look for the CO2.
Yes, respiratory acidosis means CO2 is
in the respiratory acidosis, CO2 will be high. So I'll exclude the choice B and also just B. I mean, in the second column, we also excluded B.
Yes.
So now remained
We
A,
have A,
C,
C, and E. Yes, perfect. Then skip O2, you will go for bicarb.
Bicarb in the compensatory metabolic alkalosis, and it should be 1 minute.
High bicarbonate.
It should be high. Should be
Yes.
high.
Yes.
So
Option A.
This
It
one
is high in also in choice A, in option A.
high in A. Here it's normal. E is normal.
Yes,
A,
but
A,
it's high
A.
in option
A.
A. So the
And
correct
this
answer is
low.
A.
Yes, answer is A. Perfect. Perfect. Doctor.
Thank you.
Welcome.
Thank you.
Anyone else like to continue? Hello? Anyone like to participate? Hello?
Yes, sir.
Tinashi? Hello?
Yes.
Okay. Number 5.
A 53-year-old man is on the intensive care unit following an emergency abdominal aortic aneurysm repair. He develops abdominal pain and diarrhea and is profoundly unwell. His abdomen has no features of peritonism. Which of the following arterial blood gas pictures is most likely to present? Okay, so there's no signs of peritonism, the diarrhea. I think he'll have alkalosis, metabolic alkalosis.
Here, actually, it's a clinical scenario. It's not simple like the previous questions. Okay, so the clinical background will help you to find the answer. What is the clinical information in the history and the significant data in the history? The patient has emergency abdominal aortic aneurysm repair. Okay, this means there is bleeding. Okay, there is risk of bleeding or severe bleeding, and also there is pain, abdominal pain, maybe ischemia from the abdominal pain, and diarrhea. Okay, and the patient is profoundly unwell. All these features means the patient is not well and critically ill and not well oxygenated or ventilated. Finally, the final conclusion of all these features, the patient, there is anaerobic metabolism. Anaerobic metabolism. What this means directly, anaerobic
metabolic
metabolism.
acidosis.
Excellent. Metabolic acidosis. Without numbers. Now we are not talking about numbers. We are talking about the general condition. The patient with all these features, what do you expect? It's not normal. So it's metabolic acidosis. Metabolic acidosis. There is abdominal aortic aneurysm, which may compress branches from the aorta, causing ischemia of the intestine or GIT. So it will cause ischemia. Ischemia will cause abdominal pain and profuse diarrhea. Okay, and if it rupture, it will cause hypovolemia and hemorrhage. Also, all these features anaerobic metabolism. Okay, anaerobic metabolism means more lactic acid production, so it's mostly lactic acidosis. How you will know? They give you the lactate in the options. In the options here, you see lactate. So lactate here is very high. Okay, lactate is very high here. Normally normal lactate level, no need to memorize it, but it's normally from 0.5 to 2.2 normal lactate. Okay, 0.5 to 2.2, but here it's 8. Okay, we will not start from lactate, by the way. We will go as we did before. So from the scenario, I expect metabolic acidosis. So what I will exclude any pH not metabolic acidosis, other than metabolic acidosis. pH is low in acidosis. So here it's alkalosis. No. A is alkalosis. So, sorry, A is normal. It will be excluded. B is normal, excluded. Okay. So we need C or D or E. These are acidosis. Then CO2 not have role here, and then we will go for lactate. Lactate high here. This due to what? Due to metabolic acidosis with lactic acidosis. Okay, and the base excess is very low. Here, this we will apply the first mention of base excess. Base excess normally from -2 till +2. Here it's very low, so we need more acid to be added here to correct this acid. Sorry, we need more alkali to be added to this one to make it normal, because it's acidic here. We said before, if the base excess low, this means it will be like bicarb. If base excess low means acidosis, if base excess high means alkalosis. Okay, so answer here is C. Okay, clear, Tinashi?
Yes, sir.
Okay. So anyone else interested? Hello, Dr. Fahmida, Arnaud, Dr. Bibin. Oh, we don't like to waste time calling people. So, okay, anyone can start. Hello? Anyone ready can start.
A patient is seen in clinic complaining of abdominal pain. Routine blood shows sodium 142, potassium 4, chloride 104, bicarbonate 19, urea 7.0, creatinine 112. What is the anion gap?
Yes. What is the equation of an gap? All of us know it. Sodium
Plus potassium, bicarbonate minus chloride.
Yes. So it's very simple question. You just only see the value here and subtract.
146.
So
On
yes. Okay.
23.
Later everyone can make it.
23 answer.
Yes. Okay. This question from Sheet Fawziya, if some people they don't know it, Sheet Fawziya is one of the most important sources of the exam. And inshallah, next Friday, we will start the deep condensed discussion of Sheet Fawziya in this Friday. After 5 days, we will start Sheet Fawziya and we will discuss all questions in deep details. So I collected here some questions of ABG from Sheet Fawziya to discuss, and the full discussion will be later, inshallah. Okay, continue, please. Hello?
An 80-year-old man is admitted
Yes.
to the surgical admission unit with a central abdominal pain. His blood pressure is 100/60 and his pulse is 110 beats per minute with a respiratory rate of 25 breaths per minute. He is known to have severe chronic obstructive pulmonary disease and has been a heavy smoker all his life. On examination, he has a rigid abdomen. Arterial blood gases show pH 7.24. CO2, I can see 9 kilopascal, PCO2 5.3, bicarbonate 17, basics is -3.
Okay. So, what is the question? They're asking about what is the most likely diagnosis of this finding. These are the finding of the patient. So, before reading the options, please don't read the option before you find the diagnosis from the table. Here, forget the option. Don't look for the option now, please, and look only for the table. Now I hide the options. From this table, what is the pH finding here? What is the ABG? Sorry, what is the ABG? pH is acidosis, yes. So there is acidosis. CO2 is normal. Yes. Okay. Bicarb is
Normal.
yes.
Low.
So what you can say, it's
Acidosis.
don't say acidosis only.
Metabolic.
Yes.
Metabolic.
Yes. We have two types of acidosis. So why you said acidosis only? This inaccurate answer. We can consider wrong answer. So when I say what is this, you have to say metabolic acidosis or respiratory acidosis. Already CO2 is normal, bicarb is low, it's metabolic acidosis. Okay? Metabolic acidosis. From the table, we know it's metabolic acidosis. So what you will exclude, once you know from this and this, it's metabolic acidosis, directly I will exclude D and E. Okay, and A also. We need only metabolic acidosis, B or C. Okay. Oh, here asking what is the cause of this metabolic acidosis? Is it due to COPD or peritonitis? Here you can't know from the table, so you need to check the stem one time again. Okay, the patient has what?
Hypertension.
The patient has
COPD.
the patient has COPD, yes, but COPD.
According to his blood pressure, he has hypertension and heart rate is high, so hypovolemic.
No, it's not hypovolemic. We have the patient has metabolic acidosis. Now we're asking, is this metabolic acidosis due to COPD or due to peritonitis?
Peritonitis.
Why you confused? COPD.
I think it is because peritonitis, because
COPD.
the CO2 is normal.
It's COPD.
Yes,
No,
who said
no,
CO2 is normal? Who said CO2 is normal?
I said.
Yes, perfect. First of all, how COPD? It's a respiratory problem. How COPD will cause metabolic cause problem? COPD. In the first few minutes in this lecture, we said pulmonary problem causing respiratory. Okay, it's respiratory. First of all, COPD, it will not cause metabolic acidosis. Okay. Okay, and even it has effect. Why CO2 is normal in COPD? So please, it's metabolic due to peritonitis. How we know it's peritonitis? The patient has central
Rigid
abdomen.
abdomen.
Sorry?
Patient has rigid abdomen.
Yes, and rigid abdomen,
On
central abdominal
examination,
vein,
he
and
has
rigid
rigid
abdomen.
abdomen and central abdomen.
Yes, yes, excellent. So it's peritonitis and not COPD. Okay? Okay, okay. Clear for everyone? Yes. Okay. Next one. We have only 2 questions. So please, we need to focus and make this question rapidly. Okay. Continue.
Shall I read the
Anyone
question?
continue?
Shall I read the question?
Yes, yes, please, please.
A 35-year-old man developed septicemia following a surgery for perforated acute appendicitis. His hypotensive arterial blood gas analysis reveals this. The pH is low, so this is acidosis. The PCO2 is high, so it is respiratory acidosis. And the bicarbonate is low. And he,
Yes. A big problem, right? You feel big problem
yes,
now.
yes,
Also acidosis. How come like this?
yes.
Yes, it happened like this. It's mixed. Metabolic and respiratory acidosis. Poor patient. Unlucky patient. All acidosis from respiratory and metabolic. Association like this. So associated 2 problems causing acidosis. So both systems are abnormal. Okay?
Yes.
The compensation will be from normal system. But if the other system also abnormal, it will be separated, you know? Clear? Okay?
Yes.
Yes. So it's a mixed metabolic acidosis and also respiratory acidosis. Okay? Answer is C.
Yes.
Okay. Next one also. Continue, please.
Me?
Yes, continue. I think
A
this
78.
we have one only.
A 78-year-old woman with the emphysema receiving 28% oxygen by mass. The following blood gas results. The most likely the most likely interpretation is the pH is low, so it's acidosis. The PCO2 is high, and the bicarbonate is also high. So it can be mixed, but we have the base excess, and it is high also. So we need less alkali to have to add it to correct the pH. It can be, this also can be mixed, respiratory and metabolic acidosis.
Uncompensated respiratory acidosis.
Uncompensated.
Respiratory.
Okay.
The
Uncompensated
bicarb is
please,
high, so
your name,
respiratory
please.
acidosis.
Doctor, please, your name.
Me, Casio.
Yes.
This is
Sorry?
Arnold. This is Arnold.
Okay. So step by step, this pH,
Yeah.
acidosis or alkalosis?
This
Acidosis.
Yes,
acidosis.
acidosis. First step, we will look for pH, acidosis. Then CO2 is high.
High.
CO2
So
is
it is respiratory.
Respiratory acidosis. Okay, and pH is acidosis, so the primary problem is respiratory acidosis.
Respiratory acidosis.
Bicarb is high. Bicarb is
So it's
high.
compensation.
bicarb. This
So
is compensation,
it's
but
compensated
it is not fully
respiratory
compensated.
acidosis. Compensated respiratory acidosis. The next question, it's partial or full?
The pH is not in the
Partial.
compensated range, so it's partial.
Yes, partial. So first we will select acidosis. All options has acidosis. So acidosis, acidosis, acidosis. Okay, no problem. Then metabolic or respiratory, it's respiratory. CO2 is high. So metabolic will cut. Metabolic will cut. So we have respiratory, sorry, also this one. So we have from C or E, because it's not metabolic acidosis, it's respiratory acidosis. Why it's not metabolic? Because already CO2 is high and bicarb is high. Bicarb is alkalosis. So it's not acidosis. And pH is acidosis. So now we have option C and option E. Okay. Is it partially compensated or uncompensated? We will look for the
Partially
bicarb.
compensated.
Bicarb
Partially
and the
compensated.
kidney start to compensate. So this is partially compensated. When we can say it's full compensated, if the pH become normal. Okay. Next one. Hello? Anyone like to participate? Continue? Okay, continue, doctor. Hello? This is the
Me?
last question. Yes, anyone. I don't know, no people interested to participate. So continue.
A 72 years old man with a body mass index of 18.4 has not eaten for 4 days. This 4 days following the removal of an adenocarcinoma from his ascending colon. His urea is found to be 12 millimole per liter and creatinine 346 micromole per liter. A blood gas profile is ordered. The most likely set of results would be he has not eaten for 4 days, and urea is 12. The normal range is 3.2 to 7.5. The urea is high. So I think it will be creatinine is also high. So the kidney is not functioning well. So I think there will be acidosis. Am I right?
Continue.
There will be acidosis, I think.
Yes.
And so we'll exclude the choices with high pH. The option E will be excluded, and also D.
Option A and B will be remain.
Yes,
And C also
the C also
excluded.
is normal. Yes,
Yes.
C also excluded.
You see, very simple. From the first column, we exclude like this. And you save your time to read all this. Okay?
Yes, and because the problem is in the kidneys, so bicarb will be low, and the option A, the bicarbonate is low. So I think the option A is the right option.
Yes, perfect. Excellent.
Thank you.
Excellent. So, and the condition predisposing for this metabolic acidosis, starvation, dehydration, renal failure, all this will cause metabolic acidosis. Okay, and it's partially compensated. Okay, so we will stop here, and I will share this quizzes in the group, and like a competition, anyone can answer all of them. We will share his name in a post that he answer all these quizzes. I will share in the group, so you can share with your friends, and everyone join our Telegram group and send me inbox these the answer for all these 8 quizzes. Okay, in one message, write them in one message. Example 1, and what is the full diagnosis? Full diagnosis means what? For example, non-compensated metabolic acidosis. I need to comment on acidosis or alkalosis, metabolic or respiratory, compensated, partially compensated, or full compensated, or non-compensated. The 3 parts of the answer should be written in each example. Okay, again, for example, full compensated respiratory alkalosis, for example. So you will apply the 3 parts of the answer in each answer. Okay, someone will say acidosis only or respiratory acidosis only. This answer is wrong. Will not accept it. I need to comment. I need everyone comment on all 3 parts of the answer: compensation, acidosis or alkalosis, respiratory or metabolic. And finally, my advice: you can practice more and more examples of ABG and BH and this all. And there is one website called ABG Ninja. You can go there and you will find many examples how to practice to diagnose from the numbers only. No clinical scenario there. They will give you like this. pH is, CO2 is like that, and bicarb like that. What is your diagnosis? And so on. You will practice to be trained how to, from the number, how to diagnose. It's called ABG Ninja. And regarding this example, everyone in the meeting here, you can take screenshot now, or I will share the screen, this page in the group. Everyone answer and send it to me inbox, not in the group, to give a chance for everyone to try to answer it. Okay, guys, thank you very much to join the meeting.